involving more than 4 million, that what is the likelihood of patient. This was in more than 300 hospitals, and 9% underwent more than one CT exam in a single day. There is another study, patients undergoing multi-phase CT scans and receiving cumulative dose of more than 100 millisievert in a single episode of care. So this is an episode of care, may not be in a single day. So okay, with that much for CT, let's go to PET CT. So this was another study which we published. This was only from our hospital, in which we found that 1 out of 5 patients had more than PET CT exam in a calendar year. And the age distribution was like this. And we found that 1 of the 8 patients received cumulative dose of more than 100 millisievert. And in the second study, which was also published, we had found 1 out of 4. So practically either 25% or 12%, which is larger percentage than what we had with CT. Also, we studied with the interventional procedures. So we had collected data from our hospital for 9 years, 12 interventional radiology rooms, nearly 46,000 fluoroscopic guided interventions. We estimated the effective dose and found the number of patients with more than 100 millisievert. We found 4% patients received more than 100 millisievert of cumulative effective dose, which was up to 1,000 millisievert. Median was 177 millisievert, and 42% patients received more than 100 millisievert only in one fluoroscopic procedures. 79% underwent all fluoroscopic procedures within 365 days. So essentially, with this background, we still are lacking good data on imaging in radiotherapy, the doses involved, the cumulative doses involved to the tissues, non-target tissues, and total dose from all exams. So there are some publications only in specific disease conditions, but not in the population-wise. So that is an ongoing work, and any one of you may like to pick up work in these areas. So summarizing the results so far, and before I go to the other topic, is that this is the magnitude of the patients which we have talked about, and what is known and where we are not there. So it is just logical to think that what if anyone in our family or loved one faces this situation, will we accept it? So you must have heard many people saying, if I am prescribed a CT scan, doctor, I will not say a bit about the radiation risk. This may be true for most people, but we are not among those in whom cumulative dose is of concern. So final poll question, let me run this. Are you aware of published information indicating that cumulative dose was used to deny any needed exam? If yes, then can you just think of which journal it was where you saw that? I will stop here with almost 500 responses. More than 91% saying no, 9% saying yes, but I don't see where one has seen anyhow. So there have been many debates about this issue. Some saying that so what, patients need it. And the other party says, fine, prove it. No issues if imaging is appropriate. Then one group says these are life-saving. Other group says, fine. Do we have data in how many % of the cases? So one group says stop tracking as it may lead to patient refusing a needed exam. Other says prove it. If it has happened during the last 12 years, because tracking of radiation exposure of patients has been going For the last 12 years, radiation risks are hypothetical, some say, and then others say check with the experts in the field. Some people tend to talk about these things without really being experts themselves or checking with the experts. Radiation biologists don't say so. These patients have malignant disease arguments. Sorry, malignancy does not mean death. Many cancers are curable. Some people say patients are with cancer get a lot of radiation in any way, so why worry? The response is, sorry, patients are not given radiation. This is not patient. It is only cancer cells in patients are irradiated, not the rest of the medical physicists are appointed to see that non-target areas do not get radiation or get minimum radiation. Industry has spent billions of dollars in developing machines and techniques by which non-target issues do not get radiation or get minimum radiation. So it's wrong to say or unethical to say that these patients are getting high doses in any way, so what? Let's look our history after discovery of 1895 and also X-ray in 1895 and radioactivity immediately after that. So was there ever a time in the history when situation was like this, that patients are getting such large number of patients are getting such large doses? The answer is no. So we are in an unprecedented era. So in the last 5 in 5 years, we might in the future 5 years we might have double the numbers unless we act. So with that, my topic was what, why, when, how, and how much. So I have covered what, why, when, how, and let us look at how much. This is the critical topic. As per current policy, for individual exam, the guidelines and policies are deliver only dose needed for getting clinical information. So that is the for individual exams. For series of exams, there is lack of guidance both on justification and optimization. Euratom has indicated that some exams may be labeled as high dose exams like CT and interventional and asked for recording of the doses. Suggestions in the literature have been that if, there is a paper by two referring physicians. They have mentioned that the way they use controlled drugs with risk stratification, and they have framework for the controlled drugs, maybe that can be used. So then there are other suggestions in the literature that instead of having green light in the terms of there can be yellow light, so that wait, watch and go kind of a thing. At the moment, the policies are green light for patients. So there could be some way to watch and go. Need for better information has been raised, correction factors for repair. In recurrent imaging, now we are finding the need to emphasize to radiation biologists and epidemiologists that they should develop correction factors which take into account, but otherwise at the moment we have no other way than summing up the doses from various exams at different times. I have asked ICRP colleagues, the topmost scientists in the field, they tell me that there is no other way but for us to sum up these doses. So age-related radiation sensitivity factors need to be brought out. Almost 70-80% of the patients are in the higher age bracket of more than 60 plus. So there is some research these days that the sensitivity at senior level is half than that at the middle age groups, but there is a more work needed at different age. Life expectancy issues for diseases, how to take them into account when patients with large or high doses and recurrent imaging are involved. So these are the things where is our current information and dose versus risk correct? Now that we have a huge cohort of patients moving around with more than 100 millisievert in most of the countries, radiation biologists and radiation epidemiologists could take this cohort and focus on the research on these patients. And finally, What are the research implications from the cumulative dose research, which has taken momentum in the last 3 years? It has created focus on patient safety, not just on technique optimization. Previously, we were happy till 2018, as I showed, that if the technique is optimized and justified, then we are done. We are good. So, but now we have realized that it is a patient safety which needs to be kept in mind, not just technique. It has created compelling agenda for industry to develop safer imaging machines, because current machines are not really able to impart adequate safety in such cases which you have seen in this talk. Identification, there is are publications in which we have identified conditions in which appropriateness criteria are not available from ACR, from patients who are in this cohort of high cumulative doses. So has given agenda for the appropriateness criteria development organization. Identification of what clinical condition lead to frequent imaging and to what extent. So these are the topics which have come out for future. And finally, the last slide. So there's a need to create balance in emphasis between tissue reaction and stochastic risk. There are publications which have shown that the stochastic risk in the high dose cohort is tens of times more than the tissue reactions, whereas the emphasis has been primarily on the tissue reactions in interventional. That is what I and many of our colleagues had been teaching in the last years, that tissue reactions are more important in interventional procedures, but now we have seen that it is not something which is the case. Even stochastic risks are important. Urgent need for research on radiation effects need to be there, urgent need for imaging guidelines development in recurrent imaging, and urgent need for ICRP to develop recommendations for protection in recurrent imaging. And I think with that, I wish to thank you for patient listening, and over to you, John.